metastatic colorectal cancer. So this was a positive trial with its primary endpoint being median progression-free survival. There was a benefit of almost 4.4 months in patients that received maintenance capecitabine bevacizumab as opposed to observation only. This led to this regimen, Capox-Bev followed by capecitabine-Bev, to be adapted as one of the more standard treatments for patients with metastatic colorectal cancer. Now, what are isoflavones? Isoflavones are essentially phytoestrogens. These are plant-derived compounds that have pro-estrogenic properties. Genistein was one of the earlier isoflavones that was isolated from soy and has been around for more than a century. There have been several studies, especially in the Eastern Hemisphere, that have looked at genistein in vitro and in vivo and have shown that it has anti-cancer properties. This is an over-the-counter drug that is available and again consumed in diets, especially in the Eastern Hemisphere. Me344 and Me143 are second-generation synthetic isoflavones that are manufactured by a pharmaceutical called May Pharma based out of San Diego. There have been several studies that have shown anti-cancer properties of both of these drugs. But apart from being anti-cancer drugs and suppressors of the Wnt signaling pathway, Me344, that is the drug I'm going to be talking about predominantly today, is also a novel tumor-selective mitochondrial inhibitor. So what this drug has been shown to do is it binds to the complex 1 of the mitochondrial respiratory pathway and prevents ATP production, leading to cancer cell death. So with that background in mind, let's talk a little bit about some of the drivers of metastatic colorectal cancers and resistance to anti-angiogenic agents. So the Wnt signaling pathway has been shown to have a very significant role as a driver for metastatic colorectal cancer, as well as a mechanism of resistance to chemotherapy in metastatic colorectal cancers. And the second thing I want to talk about is upregulation of mitochondrial metabolism as a mechanism of development of resistance to anti-angiogenic therapies. So to understand a little bit about the Wnt signaling pathway, the Wnt signaling pathway has a very critical role during embryogenesis, especially in the formation of the heart. In adult humans, there's about 19 Wnt proteins that play a very important role in essentially maintenance and proliferation of the gut mucosa. The Wnt signaling pathway has the Frizzled receptor, which is a transmembrane receptor, and its co-receptor, which is the lipoprotein receptor 5/6. In the presence of a Wnt ligand, this leads to phosphorylation of the LRP transmembrane receptor, essentially activating a signaling cascade that has downstream effects. There's also the destruction complex, as you can see here, which is a combination of proteins, including the APC, axin 2, GSK3A. APC protein, as we know, the adenomatous polyposis coli, plays a significant role in the function of the destruction complex. Now, the destruction complex really does what it says. It destroys, it leads to destruction of a protein that exists in the cytosol called beta-catenins. It causes phosphorylation and eventually leads to ubiquination of the beta-catenins, and eventually it's destroyed in the proteasomes. On the other hand, in the presence of a Wnt ligand, this triggers off a cascade of events which causes disintegration of the destruction complex. In the absence of the destruction complex, there is no longer phosphorylation of beta-catenins, leading to its accumulation in the cytosol. When there is increased accumulation of beta-catenins in the cytosol, it translocates into the nucleus, binds to its transcription factors, and leads to transcription of Wnt target genes such as c-Myc and cyclin D, which, as we know, play a significant role in oncogenesis of several other tumors as well. So how does this apply to colon cancers? Upwards of 85% of colon cancers have been shown to have a constitutional activation of the Wnt signaling pathway. And it has also been shown that upregulation of the Wnt signaling pathway is one of the mechanisms by which tumors develop resistance to chemotherapy. Another important point that I want to make here is the APC mutation, as we know, is an autosomal dominant mutation which causes familial colorectal cancers. And this also has a significant mechanism because it causes a defective APC gene, the APC protein, which is unable to hold the destruction complex together, causing increased production of beta-catenins in the cytosol, which eventually again leads to transcription of these proteins, which cause uncontrolled cell division, leading to colorectal cancers. The second mechanism that I want to talk about is the mechanism of how these tumors develop resistance to anti-angiogenic agents. And to understand that, let's take a step back and look at how bevacizumab works. As we know in solid tumors, as there is uncontrolled cell division, there is secretion of angiogenic stimulators, leading to dysfunctional formation of blood vessels, where there is essentially irregular blood vessel formation, leading to inadequate supply of oxygen, and this leads to the tumor adapting to essentially depend on glycolysis as a mechanism of ATP production. Studies have shown that when these patients are treated with anti-angiogenic therapy, such as bevacizumab, this leads to normalization of blood vessels. Now, when there is normalization of blood vessels, studies have shown that there is conversion from glycolysis as a primary source of ATP production to mitochondrial respiration, which is, as we know, a lot more efficient at production of ATPs as compared to glycolysis. So this is another mechanism of how tumors are able to beat really the anti-neoplastic effect of anti-angiogenic drugs. Now, with these two concepts in mind, let's talk about some of the preclinical data we have available for isoflavones. So this is a paper that was published by Dr. Pintova in 2017, where they looked at increasing concentrations of ME143 as well as increasing concentrations of genistein and their effect on colon cancer cell lines such as RKO and DLD1 cell lines. The DLD1 cell line is specifically important here because this is a cancer cell line, a colon cancer cell line that is driven by the Wnt signaling pathway. And as you can see, with increasing concentrations of these drugs, they were able to show that there was inhibition of proliferation of these colon cancer cell lines. ME344 was also shown to be 10 times more potent than genistein in essentially inhibiting these cell lines. They also went ahead and incubated ME344 in combination with 5-FU, which, as we know, is the backbone of the treatment for metastatic colorectal cancers, and also in combination with 5-FU and oxaliplatin. They were able to show that ME143 significantly suppressed Wnt throughput alone and in combination with chemotherapy. They went a step further ahead and essentially transfected these cells with stabilized beta-catenin. And they were able to show that when they transfected these cells with stabilized beta-catenin, there was no longer inhibition of the Wnt throughput, essentially suggesting that the mechanism by which this happens is upstream of beta-catenin. And this has been postulated to be through upregulation of SFRPs, which are essentially antagonists to the Frizzle receptor that we just talked about. There's a lot more preclinical data, but I think we should move on to understand the clinical data we have available for isoflavones. This is another study that was published again out of Sinai, where genistein was combined with FOLFOX and FOLFOX bevacizumab in patients with metastatic colorectal cancer in a phase 1/2 pilot study. So this study only had 13 patients, so take it with a grain of salt, but not only was the study able to establish the safety of this combination, but we also saw a pretty significant signal for efficacy, as is evident on this waterfall plot. Moving on to another phase 1 study that was published in 2015, where ME344 was studied as a single agent in patients with refractory solid tumors. So this included about 30 patients that had colorectal cancers, triple negative breast cancers, non-small cell lung cancers, and ovarian cancers predominantly. So these patients received ME344 as a single agent on days 1, 8, 15 of 28-day cycles, and then weekly thereafter. This was a 3+3 dose escalation study, and most of these patients had a median of 3 prior lines of therapies, with some having upwards of 14 lines of therapies. The dose-limiting toxicity here was neuropathy at doses greater than 15 milligrams per kg, and eventually the maximum tolerated dose was established as 10 milligrams per kg. The adverse event profile shows nausea, dizziness, and fatigue being the more common side effects. Now, as far as efficacy, that they were able to only evaluate this in 21 of these patients, and as you can see, there was only one partial response and 10 stable disease and 10 progression of disease as the best response. But what was really interesting was if you look at the duration of responses in these patients that had partial response or stable disease as compared to the prior lines of therapy, which is shown here in red, you can see that they had a pretty prolonged duration of response of 52 weeks as opposed to 10 weeks on prior lines, 47 weeks, 40 weeks, 39 weeks. Essentially, I thought that was pretty interesting. This study concluded that a single agent ME344 was well tolerated. However, as far as efficacy was concerned, this study concluded that there should be consideration for combining ME344 with chemotherapy in future trials. And that was precisely what was done in a 2017 published study where ME344 was combined with topotecan in patients with previously treated locally advanced metastatic small cell, as well as ovarian and cervical cancers. There were 46 patients who received ME344 on days 1, 8, 15, and 22 of 28-day cycles, and topotecan on day 1, 8, 15 of 28-day cycles until disease progression or toxicity. Surprisingly, there was a little bit of a different toxicity profile that was shown on this study. Fatigue, neutropenia, and thrombocytopenia seem to be the predominantly common side effects, with neutropenia being a very significant side effect, with about 44% of these patients having grade 3 or higher neutropenia. Surprisingly, again, there was no neurotoxicity seen in the study. When it came to efficacy, however, they saw no signal of efficacy, and this study concluded that though this combination was considered very tolerable, there was no signal of efficacy, so therefore they recommended that future trials should look at this drug in combination with other chemotherapeutic agents. This is a more recent study that was published at ASCO 2019, and it's a very interestingly designed study. So this is a phase 0 randomized study of bevacizumab plus ME344 or placebo in patients with early stage HER2-negative breast cancer. So this study randomized 40 patients into 2 different arms. In arm A, these patients received a single dose of bevacizumab followed by 3 doses of ME344. In arm B, patients received bevacizumab followed by 3 doses of placebo. On day 1, prior to receiving bevacizumab, these patients had an FDG PET performed. And after receiving bevacizumab on day 8, they had a repeat PET performed. Also, prior to initiating any therapy, these tumors were biopsied on day 1, followed by a repeat biopsy on day 29 after patients have received 3 doses of ME344 or placebo. Following the 29 days of treatment, these patients went on to either receive neoadjuvant chemotherapy or surgery up to the physician's choice. So between the biopsies that were done on day 1 and day 29, what they really looked at are 2 things. One was Ki67, which, as we know, is a marker for cellular proliferation, and succinate dehydrogenase immunohistochemical staining, and we'll talk about why that was done in just a bit. So the absolute Ki67 change from day 1 to day 28 in arm A was minus 13.1, and in arm B was minus 1.1 with a big significant p-value. The relative Ki67 change between day 1 and day 28 was a decrease in arm A of 23%, whereas there was an increase of 186% in arm B. They went another step ahead and looked at relative Ki67 change in patients who had vascular normalization with 1 dose of bevacizumab. Now, vascular normalization, as was defined on the study and has been shown in prior studies, is essentially a decrease of greater than 10% of FDG uptake in patients after receiving 1 dose of bevacizumab. And this is essentially because these tumors are converting from glycolysis as a predominant mechanism of respiration to mitochondrial respiration, and thereby the uptake of glucose is decreased. And the results showed a decrease of 33% in arm A versus an increase of 11% in arm B. Here are the waterfall plots for the same. As you can see, in arm A, there seems to be a pretty significant decrease in Ki67 as opposed to arm B. Similar results were also noted in patients who had vascular normalization, and this was seen in roughly about 1/3 of patients in both these arms. The next thing they did was they looked at succinate dehydrogenase staining in patients in arm A before receiving ME344 and after 3 doses of ME344. So if you remember, succinate dehydrogenase is actually part of the complex 2 of the mitochondrial respiratory chain. And studies have shown previously that when you inhibit complex 1, there is a significant upregulation of complex 2. What this study really showed is there is a successful inhibition of complex 1 when you add ME344, as you can see in the increased immunohistochemical staining for SDH in arm A as opposed to arm B. The study concluded that ME344 showed significant biological activity, enhancing the effect of Ki67 decrease in comparison to placebo when added to bevacizumab in HER2-negative breast cancer. A trend for greater activity was also noted in those patients who had vascular normalization. So based on this clinical and preclinical data, we hypothesized that adding ME344 to the combination of Capox-Bev would lead to an improved response rate. And this has the potential to translate to improvement in progression-free survival and overall survival. So moving on to the study design. So this is a randomized phase 2 open label study of Capox-Bev followed by capecitabine-Bev maintenance with or without ME344. So in the induction phase as well as the maintenance phase of these trials are both about both six cycles long, and each cycle is about 3 weeks or 21 days. Patients will receive capecitabine, bevacizumab, oxaliplatin, and ME344 at a dose of 10 milligrams per kg on day 1. Capecitabine is given as a BID dose 2 weeks on, 2 weeks off, 2 weeks on, 1 week off in the induction phase. So the advantage of this the study design is that the patient gets ME344 on the same day they get oxaliplatin and bevacizumab, thereby reducing the number of additional visits that these patients are required to go through. Similarly, on the control arm, their patients receive Capox-Bev followed by capecitabine-Bev without ME344. So this being a phase 2 study was initially designed as a single arm study prior when this application was submitted to the Vail workshop. However, it was felt at the Vail workshop that this was such a novel drug and such a new mechanism of action that for this drug to ever have a chance of seeing a phase 3 trial, we'd have to really show some really robust results in a phase 2 trial. And therefore, it was felt that this was better off as a phase 2 randomized trial as opposed to a single arm trial. The primary endpoints are overall response rates, very similar to how it was done in the Cairo 3 trial that I talked about at the beginning of this talk. Secondary endpoints include median progression-free survival, 1-year progression-free survival, overall survival, and safety and tolerability of ME344 in combination with Capox-Bev. So given the overlapping toxicity...
Testing.
I can hear you, Dr. Oh. So because of the overlapping toxicities of neuropathy as well as myelosuppression with the chemotherapy, there are guidelines that are built into the protocol of how these doses that can be reduced, and our threshold for really reducing these doses of MA344 are pretty small. We recommend 50% dose reduction even for grade 2 neuropathy, and there's also it's up to the physician's discretion to really decrease doses for any grade 3 neuropathy as experienced in this trial. Looking at the time and event table, I just want to make a point here that CEA monitoring as well as imaging for response assessment are built into the protocol, exactly how a patient would be monitored off of this trial in patients with metastatic colorectal cancer. Essentially, patients don't necessarily need to come in for additional visits, either for labs or for treatment response monitoring by imaging. Statistical considerations. So how did we come up with this number 55? So we looked at a large pool of clinical trials, phase 3 clinical trials that looked at fluoropyrimidine and bevacizumab-based chemotherapy, and we pulled data from about 5 different large phase 3 trials, and it was a pool of about 4,500 patients, and we looked at their response rates, and it was about 45%. So to see an improvement in response rates to at least a 65% and a power of 80% to detect a difference of 0.2, we would need each arm having about 55 patients. And the statistical test used was one-sided z-test with pool variance. The alpha for this test was set at 0.1 as opposed to 0.05, which is really the standard for phase 3 trials, but not necessarily for phase 2 trials. This is, of course, a work in progress. We have part of the funding from May Pharma, but we're still working on figuring out how to pay for the rest of the requirements of the trial. I have applied to grants, and some of the critiques that I've received are the lack of correlative biomarker analyses, which I think is a very, very valid point in today's clinical trial design, and we're still trying to figure out how this can be incorporated into this protocol. The other concern, of course, is how are we as a single health system going to be able to accrue patients, 110 patients to this clinical trial, and that is again something we're still trying to work out. So with that, I conclude my talk. I sincerely want to thank Dr. Pintova for encouraging me to take up this project, my mentors at the Vail AACR workshop for being incredibly educational, program directors, Dr. Malone and Dr. Kozuk for their constant support, and my co-fellows. Here's a picture from last year's graduation because we may not have a real picture from this year's graduation. So there you go. Thank you. Any questions?
Sarish, great job. And I just want to point out that Sarish from the beginning and the onset of this project has worked incredibly hard in putting this together and was of course accepted to the Vail workshop, which further improved the protocol. And we do have a commitment from Maine Pharma to provide the drug, and I have every reason to believe that we'll secure funding to run this trial.
Thank you, Dr. Pintova.
Hi, Sarish. It's Peter. I want to thank you for a very methodical and rational speaking style. It really walked us through the data. I do think from a system standpoint, this trial is should be opened. I would be enthusiastic about it. I think we can talk about ways to maybe network across New York City and some other sites that might have interest in participating. I think one thing that we can talk off online is potential concerns about CAPOX side effects and whether there's a potential for a ramp up schema. And I think that the other thing that might come to light is a bias that we're going to be accruing mainly right-sided tumors because of the sidedness factor.
Right. Yeah. Great point. Yeah, I totally agree with you. That's definitely an important point. We talk about stratifying these patients based on sidedness when we eventually analyze the statistics, but I guess that's, yeah, you're right. That's to be seen. Anybody else have any questions? All right. I'm going to stop sharing my screen. Thank you.
Congratulations.
Thank you.
Okay, so I think I'm up next, and I will start to share my screen. Can everyone see my screen?
Yes.
Okay. So I'm Tommy, one of the second-year fellows, and I'll just be presenting some research, a project that I've been working on with Quan Lin Huang in the genomics department related to cancer driver genes and their association with immunotherapy outcomes. To motivate the talk, I just wanted to start by recapping some of the existing biomarkers for immunotherapy. There's really just two that have FDA indications, PD-L1 status and mismatch repair. Tumor mutation burden has also been studied pretty extensively, and it does look like it associates with immunotherapy response, but it's not widely used in the clinic. It's not well standardized, and so it's just not something that we are commonly applying in clinic. Looking at this figure, we can see that the overall response rates for different cancers, response to immunotherapy can vary significantly from 50% for some tumors to less than 10% for others. And you can see along the x-axis that there is an association with mutation burden, but there's still some cancers that fall off of this line, and we don't really understand why some tumors respond better than others. So, what we wanted to find out was, is there something beyond tumor mutation burden and mismatch repair that we could study? Could we move beyond those two markers and try to identify other predictive biomarkers? So one of the issues with mutation burden and mismatch repair is that they are sort of global genomic features. They tell you how mutated the tumor's genome is, but they don't take into account the specific mutations that a tumor may carry. And we know that different mutations have different significance. A mutation in a BRAF V600E mutation has a different implication than some mutation in a non-coding part of the genome. And so we hypothesized that in addition to just the pure mutation burden, that the specific mutations that are present could influence the tumor phenotype, the tumor immune environment, and potentially also how the tumor responds to immunotherapy. So we wanted to look at specific cancer driver genes and how they might relate to response independent of mutation burden. And looking across the literature, there are some single genes that have been reported to be associated with immunotherapy when mutated. So in lung cancer, STK11 and KEAP1 are associated with worse response to immunotherapy. PBRM1 in renal cell cancer has been associated with better response to immunotherapy in some cases. Polymerase mutations, POL-E, POL-D, associated with better response. And in melanoma, JAK1 and JAK2 mutations, as well as beta-2 microglobulin mutations, can be associated with resistance. So we wanted to expand upon this list of genes, and we wanted to try and systematically identify somatic mutations associated with immunotherapy outcome. So our approach was to first identify a large enough data set of immunotherapy treated patients where we had both clinical outcomes as well as the baseline genomic data for the tumors. Taking this database, we could then apply multivariable regression and identify genes that associate with immunotherapy outcomes, controlling for covariates such as mutation burden. And we called the genes that we identified IRAGs. And so then we wanted to take these IRAGs and look in the Cancer Genome Atlas and see whether we could identify changes in the immune features or immune environment of the tumors with these particular IRAG mutations. And finally, we had some help from Foundation Medicine, and they gave us some summary statistics to see how common were these IRAG mutations in a real world experience. You know, if we did find these potential biomarkers, how many patients could they potentially relate to or be relevant for? So first part here is the background on the cohort. This was a cohort generated by Memorial Sloan Kettering. The original cohort had over 1,600 patients with various tumor types. So over 1,600 patients with various tumor types. After eliminating some of the less common tumor types, we brought the cohort down to about 1,500 patients. The cohort was published last year by Robbie Samstein, who's now here at Mount Sinai as a radiation oncologist and has been giving us some help with the data set. So it's publicly available. And all the tumors in this data set had sequencing using the MSK impact panel, which includes up to 468 genes, depending on the generation of the tests used. So these charts show sort of a breakdown of the cohort by cancer type. And I'll just walk us through the abbreviations here since they'll recur on other diagrams. But the most common cancer type in the cohort was melanoma, SKCM. LUAD is lung adenocarcinoma. This is bladder cancer, BLCA. HNSC is head and neck. This is renal cell carcinoma. Coad-RE, this is colorectal. GBM, glioblastoma. STAD, stomach adenocarcinoma. ESCA is esophageal carcinoma. LUSC, lung squamous cell. BRCA, breast cancer, and LGG is low-grade glioma. So 3 most common were really bladder cancer, lung, and melanoma. And this chart also breaks down the type of immunotherapy treatment they received. You can see that most of them received some sort of PD-1 or PD-L1 agent. In melanoma, there was a more significant proportion that received a combination of PD-1 and CTLA-4 agents. The second panel here is just showing the tumor mutation burden across the tumor types. The red line represents the median tumor mutation burden. So the most mutated tumors in the cohort were melanoma, not surprising, and then followed by colorectal cancer. And interestingly, in colorectal cancer, you can see there's sort of a second population that's more mutated than the rest. And this is probably the microsatellite unstable tumors. So then, taking this cohort, our analysis plan was to look at overall survival as the primary outcome and use mutation status as the primary predictor. And we considered only non-synonymous mutations. We stratified the analysis by cancer type because, as we know, different cancers can have different natural histories. And if the outcome is overall survival, we don't want to lump them all together. So the analysis was on a cancer by cancer basis. Even though we had sequencing data for over 400 genes for each tumor, we didn't want to test all 400 genes because that would cause a multiple hypothesis testing issue. And so we decided to test only the top 10% most commonly mutated genes within each cancer type. And this panel to the right is just illustrating, across the bottom, these are 10 commonly mutated genes. And just to illustrate that some genes may be commonly mutated across cancers, like TP53, but many other genes are only mutated in a significant portion of certain cancer types. So for example, APC mutated in a lot of colorectal cancers, but less commonly mutated in others. And so when we're testing for association, we want to really focus on the mutations where we have an adequate number of mutations in that cancer type to analyze. So that is just to further justify why we want to test the most commonly mutated genes within each cancer type rather than a fixed set of genes across all cancer types. We want to focus on the genes where we have adequate power within each cancer type. So these are the results of the regression analysis to identify genes associated with overall survival. So each point on this chart represents a regression for a single gene in a single cancer type and adjusting for age, sex, immunotherapy agent, and tumor mutation burden. The genes, or the dots to the right of 0, indicate genes that were associated with a worse outcome, a reduced overall survival. And the dots to the left with a negative coefficient were associated with a better outcome or increased overall survival. And the dotted lines across the horizontal dotted lines indicate different significance thresholds. We set a minimum threshold of a false discovery rate of 0.2 as the threshold to identify candidates. The false discovery rate is a way of identifying, is a way of correcting for multiple hypothesis testing, and the implication of a threshold of 0.2 is that 20% of the genes meeting this threshold may be a false positive. So 1 in 5 of these findings may be false positive, but we felt that that was a reasonable threshold to identify potential targets. So to walk through the genes that were identified, each color represents a different cancer type. So in bladder cancer, we identified PIK3CA, Notch1, ELF3, all associated with worse outcomes. In lung cancer, we identified PBRM1, KEAP1, and BRAF associated with worse outcomes. In head and neck squamous cell, TP53, ROS1, and SMARCA4, all associated with worse outcomes. And in colorectal cancer, NCOR1 and RNF43 being associated with better outcomes. In stomach adenocarcinoma, KMT2D was associated with worse outcomes, while POLE was associated with better outcomes. And in breast cancer, PIK3CA and KM2D both associated with worse outcomes. So all in all, there were 13 different IRAGs in 6 different cancer types. As a whole, these are genes that are involved in chromatin remodeling, for example, PBRM1, KMT2D, and also a variety of oncogenic signaling pathways like Notch signaling, Wnt signaling. RNF43 is involved in Wnt signaling, and other drivers we're familiar with like PIK3CA and BRAF. So some of these IRAGs have been previously identified. Last year, there was a publication from actually using the same data set where they looked at POLE and POLE D1 mutations, and they combined all the different cancer types, but the cancer types that had these mutations seemed to do better. Given that they're polymerase mutations, these may be associated with increased mutation burden, and that might be what's mediating the association better outcome. But at the same time, we did find POLE in our result even controlling for mutation burden. So there may be something beyond mutation burden that POLE is doing. This panel here is from a study of renal cell carcinoma patients, and is showing that PBRM1 mutations were associated with a better outcome for the patients treated with immunotherapy. These were all patients that had been previously treated with an anti-angiogenic agent, and it's been observed that the PBRM1 mutation seems to only confer this benefit to immunotherapy in patients who've previously received an anti-angiogenic agent, interestingly. And this is in lung cancer, a study which was looking at frequently co-occurring mutations with KRAS. And they found that when KEAP1 mutations would co-occur with KRAS, they were actually associated with a worse response to immunotherapy than KRAS alone. And these are some examples of the Kaplan-Meier survival curves from this cohort and using our IRAGs. So in colorectal, RNF43 being associated with a better outcome. You can see that these patients seem to do quite a bit better than the rest. And then in lung adenocarcinoma, PBRM1 mutations seem to be associated with worse outcomes, which is even though PBRM1 has been observed in RCC, it's not been reported in lung adenocarcinoma before, so potentially a new finding for a gene that's been put forward before. Now, it's also possible that some of these genes, excuse me, that some of these genes are merely prognostic, and regardless of the type of treatment that you give them, these tumors might be aggressive and just do poorly in general. So, in order to address this, we turn to the Cancer Genome Atlas, which has over 10,000 tumor samples, all sequenced in with overall survival data. But the cohort in the TCGA was assembled prior to immunotherapy. And so it allows us to examine whether these genes are also associated with overall survival in a non-immunotherapy treated cohort. And what this figure is showing is that in our discovery cohort, the Samstein cohort, all the hazard ratios do not include 0 in this case. I'm sorry, they're not hazard ratios. These are the regression coefficients. So, but all the confidence intervals do not include 0. Whereas in TCGA, for the most part, the confidence intervals do include 0, indicating that these genes are not associated with survival in TCGA, except for TP53 in head and neck squamous cell. So given this, we presume that TP53 may be prognostic, and we excluded it from further analysis. And perhaps it's not surprising that TP53 shows up in this way. Certainly has been recognized as a poor prognostic marker in many tumor types. So the next thing we wanted to find out was whether these genes, when mutated, were associated with changes in the immune microenvironment. And to do this, we again turn to the TCGA, which has been extensively characterized, and the immune features of this cohort have also been characterized recently in a paper from 2018, where they used gene expression data to really characterize the expression of various immunomodulators and immune checkpoints in these tumors. So using this, we could compare within TCGA the tumors with and without our IRAG mutations and see what sort of changes these mutations were associated with. So before I show the figures, I'll say that the headline or takeaway from this was that KEAP1, which is associated with worse outcomes in lung cancer, seems to be associated with an immune cold microenvironment, while RNF43, which was associated with better outcomes in colorectal, seems to be associated with an inflamed tumor microenvironment. So I'll show you a few pieces of data to support this. So in TCGA, they characterize the leukocyte fraction in these tumor samples using a DNA methylation-based method. And what we found is that the RNF43 mutated tumors in TCGA had a significantly increased leukocyte fraction than wild-type tumors. And conversely, KEAP1 mutated lung cancers had a lower leukocyte fraction than wild-type tumors. So suggesting that RNF43 tumors are more infiltrated with leukocytes and KEAP1 tumors are less so. Now this chart is showing, first of all, along the vertical axis, a number of immunomodulator genes. The top panel here are inhibitory immunomodulators, so some familiar faces like CTLA4, PD1, PD-L1 are on this list. So these are inhibitory genes, or inhibitory immunomodulators. And then in the second section, these are stimulatory immunomodulators, and they include certain cytokines as well. And what we're looking at here is when these genes are mutated, is the expression of these genes increased or decreased? And purple indicates that they are decreased, and orange indicates that they're increased. And so what you can see is that in the KEAP1 mutated lung cancers, there's a very broad downregulation of these immunomodulators, whether they are inhibitory or stimulatory immunomodulators. It seems to be just broadly downregulated. On the other hand, in RNF43 mutated tumors, there seems to be a broad upregulation of immunomodulators, and perhaps in particular, some of the inhibitory immunomodulators. So this may fit with an inflamed microenvironment where there must be some compensatory upregulation of inhibitory checkpoints in order to prevent the tumor from being killed by the immune system. And RNF43 is interesting because it's been identified in some other studies, including some work being done here by Nina Bharwaj and her group, that one of the common mutations in RNF43 is a possible neoantigen. And so that may tie together why RNF43 mutations are associated with this inflamed microenvironment and also with better response to immune checkpoints. Now, the next thing we wanted to look at was kind of going back to our original question of whether we can go beyond tumor mutation burden and mismatch repair. You know, now that we've identified these specific genes which seem to be associated with response, do they provide information on top of the already recognized markers of mutation burden and microsatellite instability? So in order to do this, we subsetted the tumors or patients by TMB and MSI, and then we looked at whether these genes were still associated with overall survival within these subgroups. So in colorectal cancer, we looked at the microsatellite high subgroup, which is known to respond well to immunotherapy. And we wanted to see whether RNF43 was still useful within this favorable response group. And it was still associated with improved survival, even among microsatellite unstable colorectal patients. And this is the Kaplan-Meier curve showing a little bit of separation between those that have the RNF43 mutation and those that don't. And then looking at sort of a poor prognostic subgroup, those who are tumor mutation low and microsatellite stable, we found that several of the genes applied to this subgroup were still associated with an even worse outcome. And so, for example, you can see that PBRM1 in tumor mutation low and microsatellite stable lung cancers was still associated with a worse outcome. So potentially these IRAGs are useful above and beyond just mutation burden and microsatellite status. And now looking at the Foundation Medicine data, we just went to them saying that we found this list of genes. We're just curious, how common are they in your data set? And this is what they came back to us with. So some of these IRAGs are actually not very common. ELF3 was not found in the 300 or so bladder cancer patients they had, but some of them are fairly common. PIK3CA in breast cancer, perhaps not surprising. RNF43 in microsatellite unstable colorectal cancer, quite common. And then in their lung cancer cohort, which is truly quite large, almost 17,000 patients, we can see that there's maybe a 2 to 5% prevalence of some of these IRAGs. So in terms of strengths and limitations, this was a large cohort with multiple cancer types. Looking around out there, there are not that many published immunotherapy cohorts that have genomic data as well as outcomes. So this was really the largest one available for now. And I think it was also important that we stratified by cancer type. Some analyses which lump cancer types together may be confounded by the different natural history of the different cancer types. We also control for mutation burden, so the associations we're identifying are independent of mutation burden and hopefully add something in addition to just looking at tumor mutation burden. And we took an unbiased approach, just looking at the most commonly mutated genes. Of course, these are hypothesis generating associations and need to be validated and explored further. In some of the cancer types, the power was still limited. And although it was an unbiased approach, our discovery is really limited only to the genes that we looked at. So it is possible that there were some less commonly mutated genes that may have significant associations with immunotherapy response, which we didn't test or didn't look at. So in conclusion, I think the IRAGs warrant further investigation as potential immunotherapy biomarkers or as potential targets for immunotherapy combinations, given that some of them are recognizable and targetable genes. I think RNF43 in particular is interesting, and we hope to learn more about it as a potential marker for better outcomes with immunotherapy. And overall, just as a parting thought, this project wouldn't have been possible without a really impressive clinical genomic data set. And so I think moving forward, in order to enable precision oncology, we need to try to really turn our patients' data into informative data sets that can be analyzed and understood and move the field forward. So just by way of acknowledgement, just to acknowledge Quanlin Huang, who's been my mentor for this project, and Tao Ting, who's a postdoc at Yale who helped with the TCGA analysis, and Robbie Samstein, who's been a really great collaborator here and really helped us understand the data set, and our other collaborators at both here and at Foundation One and at Yale as well. So with that, I'll take any questions.
Tommy, that was terrific. Two questions. One is for the RNF43 in microsatellite stable disease, was that colon or was that another tumor type that you showed, where those patients may have less bad outcomes?
It's in colon. Yeah, and we see that in, I think the other cancer that has RNF43 commonly is uterine cancer, actually.
So that raises the question about how we can begin to develop a trial so that patients can get, who otherwise wouldn't on a commercial insurance basis have access to therapy based on evolving biomarkers. Are we in the process of devising a study where we can either be tissue agnostic and specific biomarker IRAG driven, or develop basically a trial where the main eligibility criteria will be a patient who has a specific histology and a candidate IRAG.
I think that'd be great. We haven't developed any, or we haven't started moving in that direction yet. But that'd be great if anybody's interested in collaborating. Kwan is a PhD and more on the sort of research side, and I think it's been a good project as far as me bringing some clinical perspective and learning from him. But I think, yeah, that piece of translating to the clinic and trying to put the findings into practice is kind of the last mile, and we'd love to work with anybody who is interested.
So Tommy, it's great. This is very elegant studies and raise a lot of interesting points. The PBRM story in lung cancer is novel, and you should definitely follow up on that one. I have a more basic question for you. Can you clarify the clinical cohorts you are studying? Were they immunotherapy monotherapy alone? Today treatments are often either combination of immunotherapy, chemotherapy, or sequential immunochemo. You use overall survival as the overall endpoint, which is make a lot of sense. Response for immunotherapy is not a good outcome parameter like we see with targeted therapies, but overall survival is a good outcome. But the clinical cohorts, do you know is there pure immunotherapy or is it combination therapies involved? Do you know that?
Right. I would say that from what I understand, talking to Robbie and reading the publications about this cohort, is that they are immunotherapy on their own, either PD-1, PD-L1, CTLA-4, or a combination of immunotherapy agents. We do not have information on either prior or subsequent treatments. And I think for some of the lung cancer patients in this cohort, they may have been trial patients at Memorial, and so may not have, they may have been sort of prior to that paradigm change in terms of chemoimmunotherapy.
Right. Yeah. Well, congratulations with the wonderful work. Keep up good work.
Tommy, I have another question here. I don't know if you can hear me. That was really great work. I just have a question. I'm not sure if this was covered, but you mentioned that in colorectal cancer patients among the microsatellite unstable, some of the genes that you identified were still independently associated with good outcome, and among the microsatellite stable patients, there were genes still, independently associated with worse outcome. Did you find any genes in microsatellite stable patients that predicted for a good outcome to immunotherapy? Because this is the population that, we really want to try and find subgroups that could still, benefit from immunotherapy.
Yeah, I think we didn't quite find that, and yeah, I agree that as you could see overall, the findings were that the majority of genes we found were associated with worse outcome, unfortunately, and then only a couple were associated with better outcome. I think so. RNF43 is just seems to be mostly common in colorectal and uterine cancers. So we weren't able to, and it's also associated with microsatellite instability actually. So that one may not be that helpful for microsatellite stable. The other one that was associated with better outcome, POL-E, we identified in stomach cancer, but there just weren't that many stomach cancer patients overall. So that one maybe could be something to study further. And I think that group in China that published last year about POL-E and POL-D they said that they would use that as the basis for a trial to test the new immunotherapy agent. So I guess some people are looking at it.
Right.
Well,
right. Thank you.
Tommy, this is Sophia. So we actually were about to open, we were about to be one of the sites for Pol E and Pol D study with combination immunotherapy. And then there was some data suggesting that at least in some of the cohorts that were published, that increased mutational burden was more predictive of the response to immunotherapy.
Mm-hmm. Yeah, I mean, with Pol E and Pol D, I guess it is interesting. You would think that, you know, they increase mutation burden, and probably mutation burden is the whole story there. But I guess in our association, we did correct for mutation burden, and it still showed up. So I'm not sure, I guess, without further cohorts or further testing, whether Pol E on its own is really has an effect on immunotherapy response, or if it's really just that these are more highly mutated tumors, and that's all there is to the story.
Yeah, and that trial treated a couple of patients on checkpoint inhibitors, and there wasn't a significant enough signal, and it actually closed.
Okay.
I have a question on Ernesto Buchona here. I have a question on beta-catenin, which has been associated with, you know, mutations of beta-catenin in melanoma and liver cancer has been associated with immune exclusion. And I was wondering if you looked at that, and how does that reconcile with the RNF43, which is also in the Wnt pathway?
Yeah, beta-catenin, I think, is one of the genes in the MSK panel. I think it didn't quite reach our thresholds for a variety of reasons, I guess. Like in melanoma, for example, I think beta-catenin may have had a significant association at the p-value level, but because melanoma has so many mutations, and we, you know, set it as the top 10%, you know, most commonly mutated genes, or as our list of genes, I think melanoma ended up basically testing quite a lot of genes in melanoma, and because so many were tested, a lot of the corrected p-values were no longer meeting our FDR threshold. So I would have to go back and look exactly at what the association was for beta-catenin, but I think that in melanoma, I think that was why we didn't get many hits from melanoma. And in some of the other cancer types, it's possible that beta-catenin wasn't in the top 10% most commonly mutated, and may not have been in the list that was tested.
Yep. Thanks.
Thank you, Tommy and Suresh. It was great presentations. I think, well, let's move on to the grand rounds now. Who's making the introduction?
Hi, it's me, Shamala.
Okay, go ahead, Shamala.
Good morning. It is my pleasure to introduce today's grand round speaker, Dr. Alan Shih. Dr. Shih received his MD PhD degree from the Weill Cornell Tri-Institutional Program and completed residency training in internal medicine at New York Presbyterian Cornell. He subsequently completed his medical oncology fellowship at Memorial Sloan Kettering Cancer Center, where he worked with Russ Levine studying epigenetics and myeloid malignancies. He joined the Tisch Cancer Institute in January of this year, where he is continuing his research interests in epigenetics and leukemia. The title of his talk is Understanding and Targeting the Methylation Pathway in Leukemia.
Hi, I'm trying to share my screen. Is it, can people see?
There should be a green button at the bottom.
Right.
It should say share screen.
Right. Hold on.
After you hit the button, you have to look for your talk open on your desktop and click on it. You can email it to me if you want, and we can open it.
can try to switch control to you.
Do you want to email Dominique or me your slides?
It's rather large, so.
Okay, all right.
But I've now joined with my laptop, which I think.
Yeah, I don't think you can share from if you were using a different device.
Yeah.
It has to be the computer. You should be able to see share screen now. There you go.
Okay, sorry about that.
No worries.
Okay. Okay. Can people hear me? Can people hear me? Oh.
Yes, we can hear you.
Okay. So, sorry. So I'm going to be speaking today about the TET2 and IDH pathway in leukemia. And this will be work that I did mostly during my postdoc period. So TET2 mutations were identified in myeloid disease back in 2009. And they were first identified based on a loss of heterozygosity in a chromosome region 4, and a minimal deleted region was identified, and the gene mapping to that region was TET2. At that point, few people understood what this mutation did, but based on the type of mutations that were identified, it was thought to be loss of function, as these were mostly frame shifts or missense mutations. There was a clustering of mutations in 2 domains of the gene that will, in the end, turn out to be important. The other thing that was noticed is that this mutation occurred throughout myeloid disease in AML, MDS, MPN, and in certain diseases is one of the, in certain of these myeloid diseases is one of the more frequent mutations. So not only was this mutation present, but it also gave prognostic information. So in part of the work that we did in the lab, we showed that in a large cohort of patients treated on an ECOG clinical trial, TET2 mutations was associated with poor prognosis. This was also confirmed later on from the European group, where they looked at a group of more favorable patients that were cytogenetically normal, and also in those cohort of patients, especially those with a more favorable genotype, such as NPM or CBP mutant patients, those with an additional TET2 mutation did worse. And that was associated with worse overall survival and also with decreased CR rates. Around the same time, interestingly, in 2009, same year, it was published from the WashU group, a study where they sequenced one individual patient, and in this patient's genomic studies, they found a mutation to IDH1 as one of the novel mutations. And IDH1, when they sequenced that gene in a larger cohort, they found that it too was one of the more frequently mutated genes in cytogenetically normal AML. And interestingly, when they found mutations in IDH1, it occurred in the same position, so at this R132 position, suggesting that it was not a simple loss of function, but likely some sort of gain of function mutation. The ADH enzymes actually come in 3 different isoforms. And so when this mutation was, or when the other genes were sequenced, there was similar mutations found in IDH2 where certain of these arginine residues, R140 and R172, also had canonical mutations. So these recurrent mutations suggested that these genes had gained some new activity. So when these genes were studied in a larger cohort as in IDH or as in TET2, they found a mixed response in terms of prognostic information. So in the study we did, we showed in certain genetic contexts, such as in AMLs without FLT3 ITD, but with NPM1, so in favorable AML subgroups, IDH mutations actually led to improved outcomes. However, different other cohorts did not see the same thing, and with different subgroups and different mutation profiles, IDH2 was also associated with poor prognosis. Some of this may also be due to the type of IDH2 mutation. So in a very large cohort of over 1,000 patients, Ellie Papamanuel found that the IDH2, R172, and R140 actually segregated into different subtypes. And so the type of IDH2 mutation may also affect prognosis. So TET2 and IDH1/2 mutations are some of the most common mutations in AML. So in this large cohort, you can see they individually range from 10 to 15% of AML. So altogether, if you take all these 3 mutations together, a quarter or a third of all AML patients will have these mutations. And then in terms of other tumor types, TET2 mutations are relatively rare. They're estimated to be 2 to 3% of mutations found in solid tumors, and they really have an uncertain significance. It's unknown whether they're really passenger mutations or drivers. TET2 mutations are found also in lymphoid disease, and there it's thought that they may be more active as a causative agent. So they're found in angioimmunoblastic T cell lymphoma and peripheral T cell lymphoma, NOS. On the other hand, IDH1 and 2 mutations are found in solid tumor, most particularly in glioma, where in low-grade glioma, IDH1 mutations sometimes are found in greater than 80% of those low-grade glioma samples. And as in leukemia, these are the same point mutations that sort of suggest gain of function. They're also, IDH1/2 mutations are also found in chondrosarcomas and intrahepatic cholangiocarcinomas. So the reason I'm grouping IDH1, 2, and TET2 is this observation we made that when we sequenced AML patients, TET2 and IDH mutations were often mutually exclusive. So in what these are called Circos plots, where if you plot the genes along this circle and then link them with bands when they co-occurred, you can see that TET2 and IDH never, or in our cohort, rarely had any connection. So rarely did any patients have both mutations. Instead, they occurred with other driver genes in leukemia. So this suggests that these 2 genes likely function in the same pathway. So IDH1 and 2 enzymes were known quite a while ago to actually function in the citric acid cycle. So the way we get energy out of glucose. So in the TCA cycle, IDH2 is in the mitochondria and converts isocitrate to alpha ketoglutarate, and IDH1 does the same thing in a cytosol. What was found was that when these enzymes are mutant, instead of converting isocitrate to alpha ketoglutarate, they continue to convert alpha ketoglutarate to this compound 2-HG. Sort of at the same time, it was found that TET2 was a epigenetic modifier. It's a hydroxylase for methylcytosines. So cytosines in our DNA can become methylated, and it's often a repressive mark. And it was found that what TET2 did, based on homology with some plant enzymes, was to hydroxylate this methylcytosine. And the way that IDH became involved is that TET2 requires cofactors iron and 2-oxoglutarate to carry out this reaction. So in the presence of iron, vitamin C, and 2-oxoglutarate, the methylcytosine can become hydroxymethylcytosine. And in fact, it's the IDH enzymes that supply this cofactor. So TET2 and IDH are involved in hydroxymethylating the DNA, and then through subsequent work, it was understood that this was an active way that DNA became demethylated through excision repair. And because this was involved in DNA methylation, with the help of Ari Melnick's lab, we also looked at leukemia samples and found that IDH mutant samples were indeed associated with more methylated DNA. So it was associated with a more methylated phenotype. And I think that's also what's been seen in glioma, where IDH mutations are also associated with hypermethylation. So then in my postdoc, then I did a lot of work trying to study the implications of mutations in this pathway. So what we found was that when you mutate TET2, you increase stem cell numbers and give the stem cells a competitive advantage and have in vivo repopulating activity that's enhanced. So these stem cells are what we call LSK cells, and compared to wild type, TET2 mutant cells have increased stem cell number. And then we did a competitive transplant experiment where we took wild type cells and mutant cells. These are the mutant cells. And when the mutant cells with TET2 are in the same animal as wild type cells, we see that TET2 mutant cells quickly overtake the wild type cells, suggesting that when you mutate them, they gain a competitive advantage. The other observation we made is when you mutate TET2 or IDH, you also skew the differentiation potential of the cells. So even when animals are half and half wild type or mutant for TET2, if you look at the myeloid fraction, which is marked by MAC1 or CD11B, you see that the mutant TET2 has increased proportion of the cells. So even if the white cell count is 50-50, if you look at the myeloid fraction, much more of it is made from TET2, suggesting that TET2 mutant cells are skewed towards this differentiation pathway. We did the same study with IDH2 and showed that these myeloid fractions increase when you have TET2 or IDH mutations, and then they cooperate with other myeloid genes to enhance myeloid differentiation. So those animals with TET2 and IDH2 mutations did not develop leukemia on their own. So based on these patient data, we saw that additional mutations are required. So we combined the TET2 mutation with another common mutation, FLT3-ITD, which is a growth factor receptor, and when mutated becomes constitutively active. So we combined these mutations by crossing mice together and generated compound mutant mice. And indeed, when you combine these mutations, you get a aggressive leukemia. And we see that this led to a more lethal disease. So while TET2 mice developed disease eventually, that was sort of more of like a chronic myeloid disease. When we combine these two mutations, we saw a more aggressive leukemia with blast. What was interesting also, TET2 we found was haploinsufficient. So even if there's only a single copy loss, this was enough to collaborate with FLT3-ITD to induce a more lethal disease. And this is what we've seen in patients where haploinsufficiency of TET2 is observed. And similarly, we saw that IDH did the same thing. The other thing that we saw in our mouse model with IDH is that we could detect the 2HG that mutant IDH2 produces in the serum of these mice. So what's interesting that came out later on was that when TET2 is mutated, you can develop this condition of clonal hematopoiesis. And clonal hematopoiesis is where a portion of your blood is made with a clone that's mutant in TET2. And next to DMMT3A, TET2 is one of these more common genes that are associated with this clonal driver. And it was found that when TET2 is mutated and the clonal hematopoiesis is occurring in a patient, they're at an increased cardiovascular risk. And this is thought some part in due to the myeloid skewing that I talked about, where more monocytes may be produced, and these monocytes cause an inflammatory condition where they're recruited and cause atherosclerosis and can lead to ischemic heart failure. And so this is an active area of investigation in the cardiovascular groups to understand clonal hematopoiesis and cardiovascular risk. And sort of in keeping with that clonal hematopoiesis idea, when other groups have studied mutation order, so this is from Ravi Majeti's group, they find that when you look at the frequency of mutations from clones derived from the bone marrow of AML patients, you see TET2 is often one of the higher mutation frequencies compared to subsequent genes. And when they look at individual clones, there's more clones with TET2 than with FLT3. So I think many in the field now think TET2 is one of the early driving mutations. So it is one of the first mutations to be acquired, and then through addition of mutations is there clonal expansion and frank leukemia. So it's thought that TET2 is an early initiating mutation in disease. So next we went on to study how these mutations affect responses to therapy. So we looked at our mouse model and challenged them with chemotherapy. So we tested treatment with 5-FU. So 5-FU will deplete the bone marrow, and we asked then what are the remaining cells. And we can see compared to wild-type mice, TET2 mice have more stem cells that remain after 5-FU treatment. And in this standard clonogenic assay, if you look at the stem cells that can make clones, when you have 5-FU treatment after TET2 mutation, there's more clones that will remain compared to wild-type treated mice. And in an in vivo treatment model where we have wild-type and TET2 mutant cells, after treatment with a different chemotherapy agent, cytarabine, TET2 mutant cells will continue to rise, suggesting they're more resistant or recover better from chemotherapy. We also looked at the mouse model we generated that had combined TET2 and FLT3 mutations and showed that even though chemotherapy can reduce the number of cells, if you look at the stem cell compartment, the TET2 mutant cells remain after chemotherapy. And if you compare wild type to leukemic cells, at 2 weeks, you could see maybe some reduction in the leukemic cells, but at 4 weeks, the leukemia returns, suggesting that you know, when you combine these two genes together and treat them with standard chemotherapy that we give in patients, that they these stem cells are more resistant in return. This is a group a group looking at FLT3 treatment. So a different group looked at TET2's effect on more targeted therapy. So this was a study using FLT3 inhibitors, and they showed that in the setting of TET2 mutation or with IDH mutations, the more resistant patients had increased number of IDH and TET2 mutations, and they confirmed this in the same clonogenic type assay. And so TET2 may also be important in targeted therapy and not just chemotherapy. So we saw the same thing when we treated our mice, treated them with the AC220 FLT3 inhibitor, and although we could again reduce the bulk of the leukemia, where the size of the spleen will go down or the white count would go down, sort of the leukemic initiating cell, the leukemic stem cell, is never truly eliminated. If you profile the bone marrow, you can see that the stem cell population that comprises sort of the leukemic stem cells of this disease, they never change using this single targeted treatment. So using standard chemotherapy or an agent against FLT3 did not affect the TET2 mutant clone, but what else can we do? So what's known in the methylation pathway is that DMNT are the enzymes that place this initial methylation, and TET2 is involved in the demethylation pathway. So instead of targeting TET2, what you can do is target the DNMT, and in that way prevent this methylation from happening, and that's through 5-azacitidine or decitabine. And obviously it's well known here, as studies done by Dr. Silverman has shown that azacitidine has great effect in treating MDS and then in AML, and they act by inhibiting DMNT1 enzymes and allow demethylation to occur sort of passively through replication. And then through studies in patient samples from large patient cohorts done by Ben Ebert at Dana-Farber and others, we've shown that TET2 mutation is could be used prognostically to determine those patients that would be more sensitive. So TET2 mutant patients were more likely to respond to azacitidine or decitabine in this study of 213 MDS patients. In addition, they looked at ASXL1 was also a marker of response, as TET2 mutant patients who were also ASXL1 wild type were more likely to respond. So it seems like TET2 is a marker of sensitivity to hypomethylating agents. And so we tested that in our mouse model. So much as chemotherapy and AC220 did, azacitidine did increase or decrease the white count and the amount of blasts that we were seeing in the blood. But unlike standard chemotherapy, what we saw was there was an increase in the platelets and hematocrit, so showing restored normal hematopoiesis. And if you remember, the plots for those leukemic stem cells were all located in this quadrant. When we treated with 5-azacitidine, we saw a change in the profile of the leukemic stem cells, showing that the underlying disease was being modulated at the stem cell level. And because this agent acts on the methylation pathway, we're also able to profile these stem cells and show that there was hypomethylation occurring throughout the genome. And we could show that 5-azacitidine was acting through hypomethylation and not through toxicity. So looking at cell death and apoptosis markers, there was no significant increase when treating with 5-azacitidine when the mice had recovered. And in fact, differentiation markers for erythroid differentiation were increased. So normal hematopoiesis was returning to the bone marrow. We could also see more megakaryocytes, these large cells, return after treatment. So it's thought that when we restore the proper methylation status, cells could now differentiate. What is thought is that specific genes that became hypermethylated in combination of these two mutations, such as GATA2, which is an important regulator of differentiation, become hypermethylated, and gene expression is silenced because of this methylation. And when you treat with a hypomethylating agent, this gene is allowed to turn on, and methylation could be overcome and differentiation occur. So what's important to realize with these epigenetic agents is, unlike certain mutations that sort of fix a cell in a state, epigenetic mutations are essentially reversible, and these cells are not permanently blocked. And if you are able to turn on certain genes, you can reverse their leukemic state. So we did this experiment where we took bone marrow cells and put control gene, GFP, or the GATA2 factor that we thought were missing in the cells. And whereas in control cells, most of the cells stayed myeloid, and very little erythroid cells were forming that were CD71 positive, when we put in the GATA2 gene, they switched from being these neutrophil macrophage cells to more erythroid cells, showing even though these cells, leukemic stem cells, have this propensity to block their erythroid differentiation, if you turn on the right genes, you can reverse and treat this phenotype. So targeting these pathways led to differentiation and reversal of the leukemia. And a similar approach was done for IDH2, and this was a clinical trial that I was part of. We started at MSK, and because IDH2 is a gain of function mutation, it was thought, and an enzyme, was thought to be readily targetable. And in fact, Agios and Celgene were able to come up with this compound AG221 called enasidenib, which blocks the mutant enzyme by binding to the dimer interface. So by locking this enzyme in the open conformation, it blocks the conversion of alpha ketoglutarate to 2-HG and sort of restores the cell to its normal metabolic state. In the lab, we were fortunate enough to get this compound before some of the trials were done, and experiment on some of our animals. And we showed that, sort of as I was talking about with the demethylation effects, inhibiting IDH resulted in similar responses in differentiation. So in these IDH and FLT3 leukemic cells, many cells are immature and they have increased neutrophils and monocytes. So when we treat the cells with this IDH inhibitor compound, we could show that these immature cells decrease as we treated these mice with this IDH inhibitor compound. And instead of these immature cells, they differentiated into these more mature neutrophils. And even if you just look at the bone marrow of these mice that were largely white, devoid of normal hematopoiesis, after treatment, they gained normal red-looking bone marrow. It wasn't only the mouse model we looked at. We also looked at patient-derived xenografts where we took human cells with additional mutations such as MLL, and we saw the same thing where addition of IDH inhibitor increased differentiated cells and reduced these leukemic blasts. And then when we looked at gene expression profiling, we saw that compared to TET2 FLT3 mice, IDH mice had very similar response profiles. Well, when we treated TET2 FLT3 mice with azacitidine or IDH FLT3 mice with the IDH inhibitor, gene expression-wise, they clustered very closely together, suggesting that they had similar responses in differentiation. So the findings from these preclinical studies show that the effect of 5-AZA and anacetinib, AG221, are through differentiation of leukemic cells and not primarily through cytotoxicity. And by inhibiting IDH1 or 2, you can restore TET2 function, leading to demethylation. So in the clinical trial, what we did was enroll patients with IDH2 mutation and treated them with the single agent AG221 or anacetinib. And what we saw, this was in collaboration with Celgene and A.T. Allen-Stein, the lead of this study, we saw that 2-HG was suppressed. This is percent suppression by addition of the IDH inhibitor from patient serum samples. So what we also observed was that even though the suppression occurred early on in the treatment cycle, so in early cycles 1 or 2, the best response occurred subsequent cycles, suggesting that 2-HG suppression occurs early, but you need to wait for a response to occur. And so it may take longer to see a response, and that's because, as I've been saying, these cells require time to reprogram and differentiate. So what they saw in the bone marrow samples from these patients was a reduction in blasts and a return of more normal hematopoiesis. And what they saw was that the platelets increased, and there was also transfusion independence. So even in patients who may not have achieved complete remission in the bone marrow, gain benefit with treatment by requiring fewer transfusions. What's interesting with this treatment is, if you remember back when ATRA was being used for APL, there's this differentiation syndrome. As myeloid immature cells differentiate, sometimes they can release cytokines and cause sort of a differentiation syndrome where there's respiratory distress and edema, pleural effusions. And interestingly, we saw some of these same things when treating patients with IDH inhibitors. So this is a CAT scan of a patient treated, and they developed pleural effusions requiring oxygen. And when they were given steroids, many of these symptoms resolved. So that's something that you need to watch for when you treat patients with these inhibitors. To show that the differentiation is occurring, what we did was took mature cells from the patients and were able to detect that the IDH2 mutation from pre and post samples were the same, suggesting that we were not achieving mutation clearance in many of the patients, and that in fact there are mature cells derived from clones that still had the IDH2 mutation. There were a minority of samples where mutations did go away, and those patients I think tend to do better. And this was seen by a study from Courtney DiNardo at MD Anderson when she studied the IDH1 inhibitor. And as you can see, patients with mutation clearance had better overall survival, although as you can see by the number of ticks on here, they are sort of the minority of patients. And we still don't have a good understanding of who or which patients will have this mutation clearance response. So in summary, from these large clinical trials, response rates, which is quite impressive for a single oral agent in relapsed refractory AML, was near 20%. Overall response rate for both agents are around 40%, so that those are patients who had sort of stable disease, and patients who got benefit sort of required fewer transfusions. And it takes a few cycles to see a response, so they needed to continue treatment for up to cycle 5 or more. Median overall survival was 9.3 months from the enasidenib study, and similarly 8.8 months in the ivosidenib IDH1 inhibitor study. And these drugs tend to be really well tolerated. Only 5% had treatment-related adverse side effects. So what are the predictors for poor response or resistance? So we did, in collaboration with Celgene, we profiled many of these patients that didn't do as well, or as a cohort to see who didn't do as well. So those patients with higher mutation burden, so more than 6 mutations, for example, fewer of them achieved a CR, so 46% versus 10%. But that was hard to work with. What we did see was that certain genes, such as NRAS, was associated with poor response. So only sort of 1 or 2 patients who had NRAS were able to achieve a response. And from Courtney DiNardo's study, she saw very similarly from the IDH1 patient cohort, patients who had mutations in the RTK pathway were more commonly seen in these non-responders. So NRAS, FLT3, KRAS, PTPN11, they tended to cluster more in this non-responder group. One other way we saw patients acquiring resistance was looking at their molecular profile and a metabolomics profile. So for example, we studied this one patient who seemed to have a response and then acquired resistance and relapsed. So even though they had a good response initially, they eventually lost this response. And this was associated with a rise in blood 2-HG. So when we sequence, there were 2 patients like this. When we sequence these 2 patients, what we saw was they had acquired mutations at Q316 and I319. So these were mutations that were at the dimer interface and where the drug was binding. We also sequenced these patients and found, in fact, because IDH is a dimer, these mutations were occurring in the opposite wild type allele. And then when we did these functional assays, we showed that the addition of these mutations, either in the same allele or in the opposite allele led to persistent 2HG. So when you combine these two mutations, in the wild type setting, 2HG will go down, but with the addition of these second site mutations, 2HG became relatively resistant to IDH inhibitor therapy. And this is a functional assay that showed these cells retained leukemic stem cell activity by being able to be replated multiple times, whereas wild type cells were not. So IDH inhibitors were also being used in solid tumors at the time at Memorial, and from the solid tumor group, they were using IDH inhibitors in this intrahepatic cholangiocarcinoma trial. And what they observed was that this patient initially did have a response by a shrinkage of a tumor, but then developed a secondary lesion. And this patient had an IDH1 mutation to begin with. What was interesting then, when they sequenced this resistant site, they saw the addition of an IDH2 mutation. And we had seen this also in some AML patients where a resistance mechanism could be an acquisition of a mutation in the second isoform, either 1 or 2. So in our study, there's multiple ways it seems like that patients become resistant, either through these second site mutations in the IDH enzyme itself, or through isoform switching. And so in the IDH1 study, they were able to better quantify these numbers. They showed that through acquired resistance, some of these patients gained RAS-type mutations or RTK pathway mutations. Other patients gained mutations that were in the target enzyme itself or in the alternate isoform through isotype switching, and those comprise sort of a third of each patient's. And then the final third of patients gain mutations in other genes. So I'll briefly talk about what therapies are in development now. So Aton was developing this study where IDH inhibitors were being added to frontline treatment. So in mutant IDH1 or 2 patients, we were combining IDH inhibitors with standard chemotherapies, cytarabine, daunorubicin, and then continued IDH inhibitor through consolidation. And he presented this study prelim results at ASH in 2018. And so far the results seem very promising, where patients were tolerated these treatment well, and responses and overall survival seem very favorable. In patients who aren't able to tolerate intensive chemotherapy up front, there's also a study using azacitidine in combination, and according to Nardo presented this at ASH last year. This is a randomized trial where 2/3 of the patients receive IDH inhibitors with azacitidine versus azacitidine alone monotherapy in IDH mutant patients who couldn't tolerate upfront induction. And here they saw a response rate that was significantly better in combination compared to single agent therapy. So that is going forward. Sort of a very popular treatment now in leukemia is venetoclax. And the way venetoclax works is by blocking BCL2 and inducing apoptosis. And it was interesting, this study done by Ravi Majeti showing that IDH mutations, as we talked about, work at the mitochondria in the TCA cycle. And when IDH mutations occur, they disrupt this mitochondrial membrane potential. And they show that as this oxidative capacity decreases, there's more instability in the mitochondrial membrane, more oxidative stress, And IDH mutations may sensitize leukemic cells and other cells to be more sensitive to BCL2 inhibitors. And indeed, when response profiles were studied, IDH2 mutations were more common in patients who had good response. So in this study where they looked at patients who had complete remissions, so this black bar is patients who received CR or CR with incomplete hematologic recovery. Those with IDH1 and IDH2 mutations responded very favorably to venetoclax. And then some other studies that I saw at ASH and other meetings looked at how we could restore TET2 function. So as I spoke about earlier, the earliest studies looking at TET2 activity found that vitamin C could improve enzyme function. That's because vitamin C helps restore the iron that's needed for TET2 activity. So there's been studies in preclinical models showing that hematopoietic stem cells require or have high levels of vitamin C. And in fact, many patients and many of normal individuals lack sufficient vitamin C. And this vitamin C can have an effect on leukemic cell property, especially with TET2 mutations. They saw when they transplanted these leukemic cells in mice that lacked sufficient vitamin C, mice did a lot worse. So in fact, there are also trials using higher doses of vitamin C to try to restore TET2 function in sort of TET2 heterozygous or in other diseases. And interestingly, there's also been some studies about trying to study, are there any benefits actually from inhibiting the TET enzymes? So for example, TET1 is involved in somatic cell reprogramming. So people have studied compounds that inhibit TET1. And we know that TET2, when it's mutated, it causes clonal hematopoiesis. But although there's a cardiovascular risk, those patients are relatively normal in terms of cell counts. And we know that by inhibiting TET2, you can expand stem cells. So there's been some thought whether inhibiting TET2 can expand stem cells and enhance myeloid recovery. So in sort of a more bone marrow transplant setting. So that's been an area of investigation. So in summary, TET2 and IDH mutations are common in myeloid malignancies, a quarter or a third of AML patients. When they are mutated, they alter stem cell function and confer within these stem cells and a competitive growth advantage. They cooperate with other target genes to change methylation. And because these are epigenetic modifications, these changes are potentially reversible and leads to target treatment with HMAs and IDH inhibitors and lead to their differentiation. These treatments, unfortunately, are not curative, and resistance mechanisms evolve from continued treatment, either through a mutation of the target or through other factors that may be important in the downstream differentiation process. So this is my acknowledgement slide. Obviously, I need to thank the Levine Lab and all the collaborators at MSK, as well as collaborators at other institutions that helped us with some of these other assays, including AGOs and Celgene that gave us sort of the compounds early on to study. And that's it. I can take questions if people have any.
Alan, it's Ron. You showed that there was hypermethylation, and you also showed that there was increased numbers of stem cells associated with the mutations. Were you able to find which genes were hypermethylated and why it led to the expansion of the stem cell pool? Was it just block of differentiation, or was it specific genes?
Well, so one of the genes we were particularly interested in was the GATA2, and that blocks erythroid differentiation. And I think that's one of the genes we're interested in. We found some other genes when we did. We try to correlate methylation with expression profiling, and there were a select number of genes, although linking them with direct function of the stem cells has been difficult. And I think people are still working with candidate lists, and none of them have been truly validated yet.
Thank you.
Hi, Alan. This is Lou Silverman.
Hi.
A quick question for you after a very nice talk. In patients with myeloid diseases, have you seen IDH2 be a driver in either B or T lymphoid clones in any of those patients?
So I think in T-cell lymphoma, they've clearly identified IDH mutations, and they, in fact, in that subgroup, sometimes the IDH mutations will occur with TET2 mutations, suggesting that both of those pathways are really important. IDH does affect other things besides TET2. That cofactor is involved in histone demethylation also, so other epigenetic factors. So I think in that subtype, it's particularly important. In lower fractions of DLBCL, lower percentage of patients, I think they've also found IDH or TET mutations, yeah.
All right, thanks.
Mm-hmm. Oh, I see a question from Dr. Parsons about percent of loci. I don't have an exact percentage, but 5-azacitidine inhibits practically all the methyl, is a very strong methylator with demethylator without specific requirements. So TET2 only acts on certain loci. But I did see reports where certain sites that were less susceptible to 5-AZA. So I think there are studies with direct DMNT inhibitors that are being studied. You asked about other agents, so I think there are other agents being studied to sort of more completely target methylation. Okay.
Okay, thanks, Alan.
Thanks.